Greetings to all. My name is Dr. Supreet Chopra. I'm a cardiothoracic surgeon, and today I'll be throwing some light on sudden cardiac death in young adults. Sudden cardiac death in children and young adults remains a tragic and sudden event that greatly affects families and communities. It is defined as unexpected death due to an underlying cardiac cause, typically occurring within an hour of symptom onset, or an unwitnessed death 12 to 24 hours after a person appeared well. A review published in Journal of Clinical Medicine and Research in January 2023 by Ramsha et al. Explored etiologies associated with sudden cardiac death in those less than 35 years of age and emphasized evaluation methods, who is at risk, and delved into screening of SCD in potential victims and their family members. A study previously conducted in New Zealand and Australia estimated the annual incidence of SCD to be 1.3 cases per 1 lakh persons aged 1 to 35 years, with 72% of these affected being males. While some cases can be attributed to coronary heart disease, especially in 31 to 35 age range, or structural heart disease, many instances of SCD remain unexplained. These are presumed to be caused by cardiac arrhythmia syndromes associated with ion channelopathies, such as long QT syndrome and Brugada syndrome. Regardless of the age, causes of SCD can be categorized into two main subgroups. First is coronary cause and non-coronary causes, or cardiac or non-cardiac causes. Coronary or ischemic heart disease causes can include coronary heart disease, myocardial infarction, dissection of arteries, arteriosclerosis, and arthritis. Non-coronary causes can be categorized into non-ischemic heart disease or disease without structural changes of the heart. The former includes hypertrophic and dilated cardiomyopathy, valvular heart disease, myocarditis, congenital heart disease, and arrhythmogenic right ventricular cardiomyopathy, while the latter includes genetically acquired arrhythmias such as Brugada and long QT syndrome, familial SCD, and any anomaly of the cardiac conduction system. Non-cardiac causes can include neurological disorders like intracranial hemorrhage, as well as electrolyte, metabolic, and endocrine derangements. A cohort study found that SCD due to potentially inherited cardiac diseases occurs half as often in women than in men, suggesting protection by female gender. Although SCD is commonly due to coronary heart disease in the age more than 35 years, the opposite is true for younger individuals. Previous autopsy studies have found that coronary artery disease is the leading cause of SCD in individuals more than 35 years, and the second cause of SCD in individuals less than 35 years. A study conducted by ECKART et al. Found that SCD in those more than 35 years of age is mostly associated with atherosclerotic coronary disease, whereas in younger individuals less than 35 years of age, SCD was due to sudden unexplained death, which can be caused by primary arrhythmias. Now, SCD in younger individuals is often concluded as SUD, in which the heart is structurally normal and autopsy is negative. Now both these studies suggest potential causes of SUD. ECKART et al. Suggest ion channel mutations and arrhythmias, including Wolff-Parkinson-White, LQTS, short QTS, and catecholaminergic polymorphic ventricular tachycardia. Begnal et al. Identified a clinically relevant cardiac gene mutation in 27% of cases. Newmore et al. Investigated 34 cases of unexplained SCD, identifying potentially disease-causing sequence changes in 29.4% of cases likely associated with channelopathies. Medications can induce sympathomimetic receptors, including stimulant medications utilized for the treatment of attention deficit and hyperactivity disorder, ADHD, and similar disorders for school functioning. However, these medications only seem to affect individuals with pre-existing channel defects, such as LQTS, and it is linked to an increased risk of cardiac events in males. Myocarditis is an inflammatory disorder of myocardium that can be caused by bacterial, fungal, or parasitic infections, with viral infections such as Coxsackie B being a predominant cause in children. It remains a common cause of sudden death in infants, adolescents, and young adults. A nationwide study conducted in Denmark found that among autopsied SCDs in persons aged 1 to 49 years, 6% were caused by myocarditis, not including non-autopsied SCDs, suggesting underdiagnosis. A prospective study on SCD in persons 1 to 35 years of age. Bagnall et al. Found that 7% of these cases were due to myocarditis. Certain lifestyle factors also contribute to the incidence of SCD. A case-controlled study performed in Korea found that the healthy lifestyle factors, specifically lesser intake of red meat or fish, higher intake of fruits and vegetables, non-smokers, regular physical exercise, and adequate sleep showed a protective effect against sudden cardiac arrest. A prospective study on smoking in women found 2.4-fold increased risk of SCD in current smokers with a decreased risk over time after quitting. A possible presenting symptom of SCD can be categorized as prodromal or antecedent symptoms. Prodromal symptoms occur hours to minutes before the onset of death, while the symptoms that evolve gradually over days or years before death are grouped as antecedent symptoms. The most common symptoms that have been reported to precede SCD include presyncope, syncope, palpitation, chest pain, shortness of breath, generalized malaise, lethargy, infections, and gastrointestinal symptoms. Studies revealed that prior to SCD, chest pain was a predominant symptom in individuals aged 30 years or above, while those less than 30 years of age had syncope or presyncope as the most common presenting symptom. Now, how do we evaluate survivors of SCA? In survivors of sudden cardiac arrest, it is important to investigate the underlying reversible causes such as acute or chronic ischemic heart disease or left ventricular dysfunction or dilated cardiomyopathy. A thorough and detailed history of the survivor is important. Evaluation of survivors is done initially with the baseline investigations including ECG, coronary angiography, echocardiography. If the cardiac arrest remains unexplained, then further comprehensive evaluation must be undertaken. These investigations include high lead signal averaged ECG, advanced imaging like cardiac MRI, cardiac CT or PET scan, provocative tests like exercise test, stress test or epinephrine infusion, and genetics testing. AR protocols are carried out for assessing cardiac function, while late gadolinium enhancement is done to detect fibrosis in myocardial tissue. A study conducted revealed that in SCA survivors in whom the initial baseline investigations were unrevealing, a late gadolinium enhancement, that is LGE, detected a potential arrhythmic substrate in about 76% of the patients. Epinephrine infusion test was considered positive for CPVT if it provoked 3 or more beats of polymorphic ventricular tachycardia or bidirectional ventricular tachycardia. Moreover, genetic testing helps detect a pathognomic variant in a considerable number of survivors of unexplained SCA. SCD among athletes has been found to be relatively more common as compared to general population in people less than 40 years of age. The risk of athletes is found to be 0.5 to 1 per lakh of population each year. SCD is typically due to an underlying secondary condition. Now, how do we screen SCD? Screening should be done to determine the exact burden of the risk and what kind of preventive steps should be taken. Before the formation or start of the screening program, it is important to identify a population at risk and who would benefit from screening. And the American Heart Association has 14-point screening tool questionnaire used for cardiovascular screening, particularly for young competitive athletes as a part of pre-participation cardiovascular screening. As for the physical examination, this should be conducted in a focused manner with certain pathologies in mind that have distinct physical examination findings such as valvular disease, hypertrophic cardiomyopathy, aortic coarctation, Marfan's, and systemic arterial hypertension. According to the American Academy of Pediatrics, they've suggested a pre-participation physical evaluation for those between the age of 6 and 21, regardless of their participation in sports. The screening of family members is similar to the process of screening anyone who is at risk of SCD. And treadmill test or exercise stress test can be done to reveal any long QT syndrome or exercise-induced tachycardia. A set of pharmacological tests, a sodium channel blocker challenge with either ajmalin or flecainide, can be done to identify any arrhythmogenic causes that may have been missed by earlier investigations. Testing with ajmalin has shown increased yield for diagnosing Brugada syndrome, a fairly common cause of SCD. Any suspected case of inherited arrhythmias or cardiomyopathy should warrant genetic testing to confirm the diagnosis. Early treatment can help protect family members and prevent SCD from occurring. Once a diagnosis is established, management can be started accordingly. Now, ion channelopathies can be treated with lifestyle modifications by avoidance of triggers such as QT prolonging medications. And medical management can be also started, like beta blockers for LQTS. Family members at high risk of developing HCM, hypertrophic cardiomyopathy, should be screened regularly or in response to any symptoms. Being a leading cause of death worldwide, the prevention of SCD is a primary issue that must be tackled. It has been suggested that prevention of SCD and SCA can be brought about by preventing or treating the underlying cardiovascular disorder. Garg et al. Have discussed the shortcomings of current guidelines for prevention of SCD. The study has stated that implantation of SCD in patients with less than 35% of ejection fraction is not entirely a feasible option for general public because it is an expensive procedure. The strengthening of education of bystanders in the domain of cardiopulmonary resuscitation and provision of home-based automatic electric defibrillators may be a feasible option that is easier to inculcate into the masses.